think we're here today to try and inform as many veterans as we can. We're here with Dr. Bash.
Welcome, Radio Land, TV Land, and YouTube viewers and listeners. This is Dr. Craig Bash. I've been doing veterans medical opinions for 30 years, and I have dozens and dozens of these radio shows which we're going to publish on this YouTube channel, and number 1 through whatever. So thank you for listening, and here we go.
Some of the court precedents that must be applied, and that's why I was able to grant more. I might give you a brief example. Case came to my desk, Vietnam veteran, claiming diabetes. Been denied for 10 years because his individual service records did not reflect that he was stationed in Vietnam. So we couldn't look through his service records and say, oh, okay, here we see you were stationed in Vietnam. But his claim was that he landed at Da Nang, Vietnam, and transferred to a shuttle plane and flew out to a carrier, it was the USS Coral Sea, at Yankee Station, which is off the coast of Da Nang. The veteran's statement is a sworn statement, and it provides evidence that he set foot in Vietnam. Lay evidence, according to the manual, lay evidence is to be accepted unless there's evidence to the contrary. Okay, so if a veteran says, I set foot in Vietnam, our job is to compare what he told us with the circumstance, place, and type of service and decide whether that's consistent or not consistent with his experience. Well, I granted it. And I was questioned about that, all right? And said, well, why did you grant this? And I said, well, why shouldn't I? I said, well, the service records don't show that he set foot in Vietnam. I said, well, what do you know? You know he was in California on day 1, yeah? You know days later he's on the deck of an aircraft carrier at Yankee Station off the coast of Vietnam, right? Right. I said, well, how'd he get there? He said, I don't know. I said, well, you should know. If you're going to do this work, you should know how people got to an aircraft carrier at Yankee Station. The routine was you would land at Da Nang, what was servicing Yankee Station. And they routinely had shuttle aircraft and boats going back and forth between Da Nang and Yankee Station, transferring mail, transferring personnel, replenishing supplies. All of that was going on from Da Nang. So his statement is consistent with history. And there's nothing else in the record that shows it didn't happen. So he got his check. So there were times when I was questioned, but I was never found, rewarded for denying claims. That's just, I never saw that happen to anybody. There were rewards for deciding a lot of claims. So how fast an individual works might affect their opportunity for a bonus, but not the grant-denial ratio.
Mm-hmm. That forensic thing you did with the analysis reminds me of how we do things with the brain with multiple sclerosis, Like we had patients that had lost their hearing or change in their vision, and we go, well, what does the MRI scan show? It shows a little lesion in the place where they had the loss of vision or the hearing, right? We had cases like that. It's the same kind of thing. Like, how does hearing loss happen? Well, it happened because
if it's not MS,
in the brain.
Then what is it?
Right, exactly. Right. Right.
How can we tell? And what I found distressing many times, I would be getting medical opinions, and in great numbers these opinions are coming from physicians' assistants, and they would just say no, and they would just point to some literature, and literature would say, the most frequent cause of condition A is, age, let's say, for example. I said, well, okay, that doesn't tell me how you're able to determine whether this individual case is a result of being part of a minority of people who are affected versus the majority of people who are suffering with an age-related condition. Your medical opinion has to explain to me why this patient's experience is not in the minority. And the court, wasn't planning on bringing that up, so I didn't look it up. But early on in the court's jurisprudence, the court made that clear. If, for example, the opinion says 30%, 70% of these conditions are age-related, okay? The court found that, well, okay, if for example, the patient is in that group, how do you know whether he's in the 70% or the 30%? What do you point to, and how do you explain it? And I think, and when the court ruled in Nieves-Rodriguez that the rationale for the opinion and the why is the most important aspect of a medical opinion, and how we gauge the value of that opinion is predicated on reasons being offered. That's
and Bill, that same,
so very important.
That same logic you used with Da Nang, the question was why do you think he set foot in Vietnam? And it's the same kind of logic, because that's the way that the history went, and that's the way the logic goes for the transportation pathway. And the same thing in medicine. That's the way the logic goes for the medical pathways or the neurologic pathways or whatever. It's the same kind of reasoning.
Sure, like any analysis that you're attempting to do in life, basically, you're saying, okay, here's some evidence supporting one side, and here's some evidence supporting the other side, and let's see which way should we go and why. Well, I just now recalled the case you were just asking about. It was hearing, and you and I overturned an opinion of a department head of a college of neurology because he simply got his facts wrong. He was suggesting that this individual's problems with sinusitis and upper respiratory infection was affecting his hearing as an explanation for why his hearing was being different at different times in service records. And what I pointed out simply was that, no, that's exactly wrong. If you have an infection, hearing loss is going to be flat. It's going to be across the board because all frequencies are affected by infection that impairs the ability of hearing. Whereas, in this case, this veteran's hearing not only was not flat, it was variable at various times, and the times that he suffered with problems with hearing was not coincident with the periods that he was having infection. And the Board of Veterans Appeals went with us and said, yeah, you're right. So, and what I had done in that case, I had seen peculiar findings, things that are unusual regarding his hearing in his service records. And I looked at his MRI, and I did some reading on my own to say, okay, what part of the brain is this, and does it affect hearing? And I thought it probably was, since it was posterior. And so that's when I got a hold of Dr. Bash, and he pointed out, yes, absolutely. That is the area of the brain that affects hearing. So we were there. We were good. that happened. I'm really glad it did. Those were good days, Doc.
Yep. So we're back to Well, we're still doing cases. We had that reduction case recently, Bill. You want to give them some details on that one? Because it's the same kind of teamwork that requires.
Yes. Let's see, if I'm thinking of the proper case, I think this is the one where the VA, I think, looked at treatment records to reach a conclusion that a brain tumor, was in remission. And, in fact, when you reviewed the imaging, it clearly demonstrated that it was not in remission. It was quiescent, but not in remission. and it was active. And the poor veteran was facing a reduction from 100% to 0%, which is wrong in and of itself, but that's a different argument. But the proposal to reduce was incorrect. And again, this proposal to reduce was a result of accepting evidence that was incomplete. And once Dr. Bash took a look at the records and saw what the facts were medically, we were able to bring that to the attention of VA. And they quite promptly reversed their position on that, didn't they? That was like, less than 2 months? Yeah,
so that
was pretty quick.
That concept, we had another case where it was 59 days. And the concept is that sometimes they'll match up my DBQ or my medical analysis with the clinical situation, and then we'll take that and see how it compares to what Bill's knowledge of the law is and kind of meld those two things together, right, Bill?
Yeah, my philosophy when I was a representative was always, I want to make the rater's job as easy as possible, because I'm going to give them the evidence they need to make an accurate decision. And I'm going to point to the authorities so they know where to look it up if they need to, if they're not familiar with this part of the rules or the law. Here's where you can look it up, so that I would always present a case in that way. Even back in the 1970s, when I was way out in the field, all the way back then, I would make a point of doing all that development work and getting all those documents, getting all those treatment records, witness statements, putting it into as a complete package. Decades before VA came up with what they now call a decision-ready claim. That's the way I was doing business decades ago, and if everyone could do that, I truly believe we could help. I truly believe that VA would be able to achieve its mission more accurately and faster with our help. And I think if every veteran and every representative were to focus on that mission, everyone would benefit.
Well, Bill, you make it look easy, but in order to do that, you have to have a really good, deep knowledge of the law, and you have to have a good, deep knowledge of the medicine, because you have to figure out what pieces to pluck and cut and paste.
Yes, it takes experience. You can't walk in off the street and start making these rating decisions and be accurate. Now, let me say, VA has made a concerted effort to make it as simple as possible by creating a software program in the computer that the rater is required to use that will tell the rater what to do and how to decide the claim. But when it comes to evaluation of disabilities, there are many findings, there are many effects of disability that require an understanding. You have to understand how a disability affects a person's life in order to determine how disabling it is. And I was somewhat uncomfortable. VA has what they call the, excuse me for getting the language just now, but there was a software program that says this is how disabled the patient is. And basically you transfer the findings on the DBQ into the software, and the software will tell you what disability evaluation to assign, even for mental illness. I've always struggled with that because there is a built-in bias. Now, I don't tend to suggest that that's intentional, but when you're evaluating mental illness, you have to consider all of the patient's symptoms. But in the evaluation builder, that's the title of the software program I couldn't remember a minute ago. The evaluation builder only prompts for those examples of symptoms that exist in the rating schedule for mental illness. Depression, sleep disturbance, hallucinations, okay? So if a patient has intrusive recollections, flashbacks, nightmares that are impeding their ability, if a veteran is sitting at a desk and he's trying to do some work and suddenly something triggers a memory, a sound maybe, maybe the individual is startled by something, and the same feelings they had when they were startled by a bullet whizzing past their head comes back, and it forces them to stop working and deal with that issue again. That interferes with their ability to produce with speed, with accuracy, with consistency. It interferes with that. And yet, these symptoms I described, so typical of PTSD, are not in the rating schedule. And so he could be suffering with flashbacks 4 times a day, forcing him to go sit someplace quiet and calm himself down, and he gets no compensation for it. And so in order to comply with the court order in the case called Mauerhan, Mauerhan ruled that when the rating schedule says symptoms such as hallucinations and depression and sleep disturbance, that's not an all-inclusive list. So if the patient is also suffering flashbacks, intrusive recollections, I have to compensate him for that. Problem is the manual, the evaluation builder software, and the training never tell the rater how to compensate the veteran for flashbacks and nightmares and intrusive recollections. You have to be somewhat knowledgeable of that, and I don't think I've encountered maybe 3 raters ever that could give me a satisfactory explanation as to how to deal with that issue. Okay, so I'm really not certain that veterans with PTSD are being fully compensated for the severity of what that condition does to their life and their earnings. And so that's why it's important to me to share that information. Now, I'll explain what I did in that circumstance. The evaluation builder for mental disorders gives you the opportunity to click up one evaluation. So if the evaluation builder, considering symptoms that are specified, justify a 50% evaluation in accordance with the computer program, I have the authority to click it up to 70 and put in an explanation. And I did that frequently and regularly. And I explained how the additional symptoms are also affecting, which are not contemplated by those symptoms described on the examination or not described in the software. And I was never challenged. No one ever challenged my decision to increase those evaluations. And yet it was made clear in the training that whenever you do click up one, central office will review that decision for accuracy. And in all those years, none of my grants were ever questioned by central office. So I'm satisfied I found a satisfactory solution. And I tried to share that with other raters and tried to help them persuade them to take similar decisions. And generally speaking, the raters were reluctant and hesitant for fear that they would be found to be in error for using symptoms not in the schedule. So that will remain a problem for a while, and I hope that will someday improve. But now.
So Bill, I'm going to go back to
Yeah.
back to reduction again a little bit, you know. So that guy,
yeah.
the other case we had, the guy with the 59 days, I think he was diabetes, and the secondary conditions were the part that they didn't take in consideration, right? The fact that he had some.
Then when evaluating diabetes, the manual expressly says you must consider all of the complications of diabetes. So is there peripheral neuropathy? Is there nephropathy? Is there diabetic retinopathy? Okay, whatever. And diabetes can cause a lot of complications, affect a lot of bodily systems. All of those must be identified. So if we're adjudicating an initial disability claim for diabetes, we provide a general examination, and that physician then identifies the complications, and then we get specialty exams by specialists in each of those areas, be it ophthalmology, neurology, urology, okay, whatever is affected. Now,
so this
remember we mentioned, yeah, and if the rating is proposed to be reduced, the first mistake, if you tell the veteran your reduction is effective in 59 days, you're wrong. The VA says we're reducing you in 59 days, on the calendar. That's an error, okay? And it has to be reversed and reinstated. Then if VA wants to propose again with the proper evidence, give them another 60 days, not 59, and have at it or try. But like I said earlier, typically these reductions are effectuated with limited evidence and less than fully satisfactory evidence. And so once that reduction is reversed and the prior evaluation reinstated, when you fully develop the evidence, that typically reveals that it's worse, not better. It's not improved.
So Bill, we think historical cases where a patient was like that, maybe, and then they tried to reduce them to 50%, and then maybe I came in and did a DBQ, and then we found that he couldn't walk, and he used wheelchair, crutches, falling, and the patient actually ended up with maybe SMC level benefits when they proposed to reduce them to 50%.
Yes, and during my time as a decision review officer, many people kept coming to me and asking for my advice on special monthly compensation. Even Secretary Shulkin's office, an attorney working for him, came to me. He says, I called my friends at Compensation Service, and all three of them told me to call you. So we'll probably have to do 3 or 4 presentations on SMC, because that is extraordinarily complicated. But there are some clear thresholds that are easy to reach with proper evidence. We need to do that.
Really, the SMC really conceptually gets into this whole idea of secondary conditions. That's what raters. I mean, medicine teaches us about that, but the raters don't understand the medical secondary complications, and that's what SMC tries to sort of work on. So it's a weakness. It's really a weakness in the training because it's complicated.
That is a sacrifice made by trying to create consistency across the board by simplifying the rating decision. If the doctor didn't say it, if the record doesn't show it, don't address it. Move on to the next case. I think in some of the debates that I had as a decision review officer, it was typically, well, why are you asking for this additional development? I remember one case very distinctly. It says, it shows he's entitled to 100%. I said, yeah, but I can't determine his SMC. So I got to have that exam. I said, what I really want to do, I want to give him his 100% now, get his exam, and then see what the SMC would be. But the manual expressly prohibits that, so I can't do it.
So the paperwork trail goes, I have 65,000 codes in medicine. They're boiled down to about 2,000 codes in the VA, right? So you have a pyramid going, and then those pyramids down to like 70 DBQs. So you're asking one doctor to try and analyze a DBQ when his colleague that's a specialist might have 6 or 7 years training in that small little subsection of the secondary condition, and all that stuff gets eliminated because the DBQ is so narrow.
Yes. And then as medical knowledge evolves and the terminologies used in the practice of medicine continue to change and evolve, we're still looking at essentially a rating schedule. Well, it's been some adjustments, but I mean, the rating schedule, this since the current version is 1930. I think the initial version was probably about there 1917 or 1918 or something, but
Yeah. So specialized examinations are really important, and to not be able to do those limits the rating. Medications, SMC.
And I'd like to offer this one quote. Judge Peace at the court made a single judge memorandum decision. Okay? It's not a precedent decision. It's a memorandum decision, which means this is what the judge is telling us in this case. But what she's telling us in this case is that the law, when it comes to the evaluation of disability, has already been well defined in the court's precedent. So we don't have to revisit that. We don't need a panel to establish the precedent. The precedent already exists. And in this case, the BVA decision failed to comply with the governing precedents of the court.
Thank you all for listening. That ends this show. And now I'm going to zoom off.